Hello, everyone. Welcome. You've made it to part 2 of our Sublocade series. Before we jump in, if you're familiar with our webinar platforms, we do a few polling questions. So I'm going to go ahead and launch the first one. You can go ahead and answer that on your screen. And about 5 more seconds to complete this. Great. So we have about 72% of the participants that are prescribers. Next question. Five more seconds. All right, about 20% of folks on the line are from rural or remote areas of the province. Five more seconds. All right, so about half of you said that you understand the current coverage process for Sublocade, and just a heads up that our part 1 of this series goes into this in detail. So if you want to refer back to that when we post the recordings, you can go ahead and do that, but we won't be covering it in detail in this session today. Next question. Five more seconds. And the results of this poll is very variable, everywhere from not at all to very comfortable. So we're hoping for those folks that are in the not at all somewhat range, this session will be really helpful for you as we're going to be diving into some cases with a few of our prescribers that have been doing this work for the past year. Very last question here, and we'll get into the session. Five more seconds. And unsurprisingly, no one voted yes for this question, and we do recognize this is a very new listing for folks. So we're glad you're here, and we're hoping to get into some practical applications of prescribing this medication to patients. So thanks for joining us. I'm going to go ahead and share my screen, and we're going to get started. So welcome, welcome. As I said, this is part 2 of a 3-part series. So if you joined us for part 1 of this series, we really honed in on the administration of Sublocade. So you would have heard coverage, storage, some prescribing considerations, actual administration of this medication. But today is really about the practical applications. We're going to do this through case-based learning, and we have a couple of prescribers on the line that have quite a bit of experience with this. Before we dive into the content today, we do want to respectfully acknowledge the land on which we're working is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. As always, this is a provincial webinar, and so taking that moment to reflect on the lands in which you're calling in from and listening and learning is an important part of this process. So here's our agenda today. We're going to spend just a couple minutes on the welcome and introduction, but then we're going to dive right in. We're going to be talking about some applications that have been used in Foundry and some of the youth populations. And then we're going to spend the back half of this presentation talking about applications of Sublocade in correctional facilities and their lessons learned. We will take time for questions and discussion at the end, but what's unique about this webinar is that we're going to be watching the chat throughout the entire presentation. So a good reminder to our presenters that after each case, we'll give an opportunity for folks and see what's in the chat to see if you want to talk through anything or if you have suggestions or questions based on that case. So go ahead and ask us our questions all along this, and we'll try to get to those as they pop up. And with that, we have two amazing prescribers here with us today. It's so great to be able to share learning, the early learning. Oh, if our presenters could mute themselves. Sorry, we can hear some background noise. We have two amazing presenters. So first, Dr. Nadir Sharifi, who is the Medical Director of Correctional Services Canada and the Addiction Medicine Lead with the BC Mental Health and Substance Use Services. And then we also have Karen Mitchell, who is a nurse practitioner and adjunct professor with the UBC School of Nursing, and she does her work at Foundry Inner City Youth Program with Providence Healthcare. And with that, Karen is going to take us away on the practical applications of Sublocade at Foundry. Thanks, Karen.
Great, thanks. Can people hear me okay?
Yep.
Okay, well, it's really great to be here, and thanks for starting with the land acknowledgement. So we'll just get right into it. The next slide, please. So I just wanted to say that I have nothing to disclose. None of us at Foundry have any connections to or financial support from the drug industry for this. Okay, so just a little bit about Foundry, where I work. So Foundry is a network of youth health and social services centers. So there's 8 centers across BC, and we've been around for about 3 or 4 years now. Foundry Vancouver was the first one that opened, and that's the one that I work at, and it's the prototype. So it's basically a place where any youth ages 12 to 24 can come in and get primary care, substance use services, and social services. The majority of the work at most of the foundries is more along the prevention and early intervention, but Foundry Vancouver is a little bit different because we're the home to the Inner City Youth Program. And that's a program for young people who are in need of intensive case management because they have high-risk needs, and it's youth 16 to 24 who have significant mental health and/or substance use disorder and have homelessness or other psychosocial barriers. So some of the things that we would come, oh, can you go back, please? Thanks. Some of the concerns we commonly see are things like polysubstance use, concurrent other psychiatric and medical problems. Now we do, my role on the team, I'm the co-founder and lead prescriber for our Outreach OAT program, which is Outreach, and that's for high-risk youth ages 12 to 24. And now recently we've also added Outreach Pandemic Withdrawal Management for this population. And the Sublocade program that I'm going to talk about today, we've been running since the spring of 2019. So the first patient we're going to talk about is Jeff, who's a 23-year-old male. So some background on Jeff. So Jeff came to us after he had quite a severe course of substance use. So he had been attending school in the US on a sports scholarship, and he had a history of using a little bit of substances, but nothing significant, more experimental use of different kinds of party drugs and that kind of thing. While he was in school, he developed epilepsy, and it became very unstable, and he was having frequent seizures and a lot of memory loss, and it was to the point that he actually didn't remember how to play the sport that he was on a scholarship for. So his life really spiraled after that. He became quite depressed, and his substance use escalated to daily opioid use. That led him to become homeless in the downtown east side. He was hospitalized following a violent incident in the downtown east side, which is how he first came into contact with us, was through VGH, where Dr. Azar, who's the medical lead for our team, works. He attended an inpatient treatment program and then moved back in with his parents, and then came to us to talk about Sublocade. And just some strengths about Jeff. He's a very hardworking, kind individual. He's resilient, very insightful, and just a really great youth to get to know and work with. So his substance use history, as I said, he had experimental use with substances more as a younger teen, but his opioid use really started at age 20 following the epilepsy diagnosis, and it progressed to IV drug use by around age 22 to 23. He also uses cannabis since age 14, and he says he uses that now. That's the only drug he uses now, and that's because he finds that it helps with the aura when he's about to experience seizures or if he feels like he's going to. Other than that, he smokes cigarettes, he doesn't drink alcohol, and he's never had an overdose. So when he came to us, he was abstinent from all substances except cannabis for 2 months, and he was stably on Suboxone 32 milligrams sublingual daily. He had a history of trying Suboxone, methadone, and Cadian in the past, but hadn't really stuck with it until this particular time, which was when he came to us. So a little bit more about him. So he has the history of epilepsy, which is actually on the monograph of Sublocade as a contraindication. So we consulted with neurology and psychiatry about this particular patient before starting him, and he was cleared to do it, and he is getting ongoing follow-up from neurology. Otherwise, he's healthy, and his blood work and ECG were normal. Psychiatric history is positive for depression and anxiety, and a history of suicidal ideation. And his medications at intake were Suboxone 32 milligrams, topiramate 200 milligrams HS, and lacosamide 200 milligrams BID. Next slide. So when Jeff started on Sublocade, the first thing we did was the day before he had the first dose, he discontinued his Suboxone. Then he came in and he got the first dose of Sublocade 300 milligrams. A couple of days later, our team RN started to call him to reach out and see how he was doing, but he was difficult to reach and didn't return their calls or texts. A few days later, on day 6 or 7, he did reach out to the RN, and at that point was experiencing increased anxiety and some symptoms of withdrawal with a SAOS score of 9. He hadn't used any opioids and was looking for how to manage this. So at that point, they would have contacted Dr. Azar, who added some PRNs of Suboxone. By day 10, he was reassessed. He had used 2 of those tablets of Suboxone and had no further withdrawal. So we've continued him at Sublocade 300 milligrams monthly since then. So some of the challenges was early on engagement, just building some trust between Jeff and the RN team. I think this was one of the first times that he had engaged in like an intensive service like this, and it took him a little bit of time to build trust, but he did warm up. And one of the other challenges was the withdrawal symptoms that I just talked about, which resolved after a couple of weeks. The major medical challenge is the ongoing epilepsy. His memory is improving, and he's not having seizures as frequently, but he had a seizure most recently in February. And he right now is looking into surgical possibilities with neurology. Other than that, the main side effect he suffered from was occasional constipation, which Senna was effective for. Lactulose caused vomiting. I usually actually prescribe PEG, polyethylene glycol, but in this case, Senna was effective. So the current picture now, 11 months later, is that Jeff is stable and his polysubstance use is in remittance. And he's remained on Sublocade 300 milligrams monthly. Currently, he has good engagement with the care team. His urines have all been negatives for everything except for cannabis, with no opioid or crystal meth use in 11 months. He's working full-time and renting an apartment on his own, has a good relationship with his family, and no further withdrawal. And he's continuing to follow up with neurology around his epilepsy. So that first case was one that was fairly straightforward. So we'll move on to the next couple that are a little bit trickier for some different reasons. So the first one's Hannah, who's a 23-year-old female. So she had been followed by ICY since age 18. A little bit of her personal history. She grew up with family in Vancouver. She had been in foster care for about 6 months at 18. And then after that moved into youth supportive housing, which is operated by Foundry. At this point, well, currently she's staying with parents, and she had been going back and forth with her parents. Her source of income is persons with disability, and then she also supplements that by doing sex work. She's 2 courses short of her high school diploma, and she enjoys attending music festivals, and she volunteers at them as well, traveling, social justice activism, and she's interested in alternative medicine. So Hannah's substance use history, she first used opioids at age 17, and at her heaviest, she was using about 3 to 5 points daily IVDU. At the time of referral, she was using intermittent Suboxone and opioids. It was really kind of confusing what she was doing. She had a bunch of Suboxone at home, and she was basically deciding on a daily basis how much she would take, and it would be anywhere from none to 0.25 to 8 milligrams, and it was just very confusing what she was actually doing. She also was using crystal meth, first use at age 16, and that's been intermittent and mainly used to prolong the effect of opioids. She'll occasionally use cocaine, occasionally use psychedelics. She does vape cannabis daily and finds it helpful for opioids. She doesn't see that it has any negatives in her life, and she is a non-smoker. So her diagnosis in terms of substance use are severe opioid use disorder, stimulant use disorder, and cannabis use disorder, and her most recent overdose was in August 2019. So a little bit further history. So she also has a history of ADHD, and she's on the autism spectrum. She has a mood disorder, and she also has borderline personality disorder. She attended DBT at Foundry, but wasn't able to complete it, so hopefully we'll be able to return and complete that soon. And otherwise, she's healthy. She has a history of iron deficiency anemia, but otherwise medically well. No allergies, and her only medications at intake were 0.1 milligrams of clonidine PRN, and then she had Suboxone with these unknown doses. She had previously tried methadone, only got to 35 milligrams, and she really found picking it up daily at the pharmacy was interfering with her life and her other goals. So she was switched to Suboxone, but was very inconsistent with taking it, altering the doses, and was going in and out of withdrawal. And the team was worried that with this intermittent Suboxone use, she could either put herself into precipitated withdrawal or just not have enough coverage and have an overdose. So when we talked to Hannah about her goals, one of the things that we quoted her saying is, I'll probably still use down on Sublocade, but if it's not rewarding, I'll stop. So that was an interesting statement, that she did have an understanding that it was a partial agonist and that it would still allow her to feel opioids, but that it would be reducing a bit. So I think she was looking at it as a bit of experiment on herself. So some of her motivations was to prevent going in and out of withdrawal. She didn't want to be taking daily medications or going to the pharmacy. She wanted to be protected from overdoses, and she wanted to be able to travel and go to music festivals with having money and not being dope sick. Some of her concerns were what will happen when it's time to discontinue the Sublocade, whether or not she would be sick and how we would manage that, what the side effects may be. And one of her major concerns is that Sublocade, once it's injected, it leaves a palpable bead at the site of injection, which is like right by the umbilicus. And it's about like a round bead, I'd say about like an inch diameter. And it's palpable, and she does sex work. She's quite slim, so she was afraid that, concerned that that might be visible and might turn some of her clients off and get in the way of her ability to make money. So in November 2019, she decided to start the Sublocade. She reported pain at the injection site, but that was manageable. She experienced pain for about a week post-dose, but was able to tolerate it. She tried to use opioids and found that she didn't get the same high. And she did reduce her use to about a quarter of what she had been using previously. She denied any crystal meth use and had negative urines for it. And she said her sex work had decreased. Her drives to use, or the role that it plays in her life at that point was she was feeling quite fixated on needle use, and giving that piece up was difficult for her. And she just really didn't want to be in withdrawal. And another thing she identified was boredom, which is an interesting one because a lot of our youth say that. And I think what they call boredom is something much more extreme than what is usually referred to with boredom. It seems to me more like an anhedonia that's usually brought on from using stimulants and opioids and any number of things. So really helping the youth to stabilize on oat so that they can start to work through some of what they experience as boredom. So since being on the Sublocade since February, she has had her urines only positive for buprenorphine and cannabis. And her most recent injection was given on May 13th. So Hannah's major concerns is that she's been experiencing what's either breakthrough withdrawal symptoms or side effects, basically the whole time. So initially the withdrawal symptoms were worse just when it was coming up on when the injection was due. So we were thinking maybe her opioid requirements weren't being met, which was one of the reasons why she wasn't stepped down to 100, which either, I'll come back to that. And at this point, we just haven't been able to figure out any timing, any like relationship between the time the injection was given and when she might be experiencing the withdrawal symptoms. Her symptoms include cold sweats, nausea, anorexia, anxiety, and cravings. And she really doesn't like to take additional medications. So she wasn't keen on taking Suboxone, PRNs, or really clonidine. So some of the things that we did to try to address this was keeping the dose at 300 milligrams monthly. Now, this is actually off-label and is the case in all of the youth that we've seen at Foundry at this point, and I'll talk about that a little bit more at the end. So we kept her at that dose, and then we also increased her frequency from Q4 weeks to Q3 weeks after the 4th injection. We've continued to provide Suboxone and clonidine PRN with minimal relief, and more recently we've offered her oxybutynin for cold sweats. It says here that the youth declined, but she's actually now agreed as of last week. So we'll see whether that works. So some of the benefits are overdose protection, reduced substance use, not having her medications witnessed, decreased need for sex work, negative urines, and just overall improved psychosocial stability. And she's able to stay with her parents and has a better relationship with them. So really the main concern right now is she's continuing to experience what she feels to be withdrawal, despite Sublocade dose and frequency being at 300 milligrams and Q3 weeks per over 8 months. So she's now at steady state and at steady state above what the monograph would recognize. So it doesn't make sense to me pharmacologically that this would be withdrawal. So what is it? I'm hoping with the oxybutynin, we're going to see some resolution of this, but at this point, if that's not the case, we'll have to renegotiate with this youth and hopefully find a way to keep her on this medication, because other than that, she has done quite well. And the last case I'll talk about is Jonathan. So Jonathan's a 16-year-old male, and he was referred to us by BC Children's Hospital after an overdose in May of 2019. He was living in a group home with MCFD for 2 years. He had a 2-year history of severe substance use disorder, including multiple overdoses requiring naloxone. He had pending legal charges for possession of weapons and threats towards his foster mother. There was also concerns that he was being sexually exploited by adults who were providing drugs to him. He stated that he enjoyed playing basketball, watching cartoons, listening to music, and doing art. So he began to use opioids about 1 year before we met him, and his heaviest was using 3 to 5 points of fentanyl most days. He had severe cravings and would experience intermittent withdrawal. He said that the role that the substance played in his life was to help him cope with stress and anxiety and to help him get through the day. In addition to the opioids, he also was using crystal meth and crack with unclear onset and last use, but the crystal meth was more significant than the crack. Doesn't use alcohol. He has been a smoker of a pack a day for 5 years and was pre-contemplative about that, and also frequently using cannabis since age 12 up to 5 or 6 grams daily. He wasn't able to provide us with more of a history beyond that. So his diagnosis for addictions were opioid use disorder severe, stimulant use disorder severe. I should have put cannabis use disorder, that should be added, but he had no history of being on oat. So a little bit more about Jonathan. his psychiatric and developmental history. So he has a moderate intellectual disability. He also has learning disabilities with expressive language and global learning disabilities. He has ADHD and also an unspecified neurodevelopmental disorder. Quite a vulnerable young guy. Medically, he's healthy, and his baseline blood work and ECG were also normal. And at intake, his medications were risperidone 2 milligrams, trazodone 75 milligrams at bedtime as needed, and lisdexamfetamine 60 milligrams daily. It was difficult to determine what Jonathan's goals were in this situation because he just really had a hard time articulating what it was that he wanted or just even what the substances were doing for him. It wasn't nonverbal, but close to that. So he was able to say he was interested in working on abstinence and he was willing to try Sublocade. We felt that he was at extremely high risk of death and other serious consequences, so went ahead with the first dose. So we couldn't really nail down his goals, but the team's goals were to protect him against overdose, reduce his substance use, prevent cravings and withdrawal, prevent exploitation, and hopefully just improve his overall wellness and enjoyment of life. So in June 2019, Jonathan was started on OAT for the first time, and that was done by Dr. Azar, and that was done as an outpatient, and we actually titrated him to 20 milligrams within a day and a half, and it was an interesting titration. We did it 2 milligrams at a time, but that's a different story, I guess. There was some adherence issues. One of the major things is he disliked the taste, and that's common for a lot of our youth. I'll often suggest that they take it with like a Listerine breath strip or a Tic Tac to try to mask the taste, but that really wasn't even working for him. In July 2019, he was mandated to go to the Orchard Treatment Center, which is not the one on the island. This one is a court-mandated treatment center for adolescents, but he was discharged for possession of substances. So in August, he came back to the Foundry and initiated Sublocade. At that point, his urine was positive for stimulants, opioids, including fentanyl, cannabis, and buprenorphine. And there was concerns that while he was on Sublocade, he was beginning to use more crystal meth, which he denied, but the urines were positive. Unfortunately, Jonathan found the injection to be very painful, and he declined to receive another dose. So we restarted him on Suboxone, and he stabilized on 12 milligrams daily. And then in October, he moved to the Prince George area to attend a treatment center, and his care was transferred to the Foundry in Prince George. So some of the lessons learned. Dosing. So the monograph says to give people one dose of 300 milligrams, and then it should go down to 100 milligrams every 4 weeks. We didn't find that we've been able to step down the dose on any of our youth. And it's hard to know why that is because there hasn't been a lot of study. Our youth tend to have very high opioid requirements. And I think some of that may just be the difference of research being done on this drug using like a heroin population versus fentanyl. But that's just me trying to extrapolate like a reason for this. And other considerations around dosing is subpopulation. So like with the younger youth, Sublocade is actually not officially indicated for under 18 years old, but you can access it, but it's a little bit more of a process. And so I'm not sure what other factors may be leading to the need of the higher dose. We also found that some patients, even at this dose, required some PRN, Suboxone, and/or clonidine for breakthrough symptoms. And our nursing team also wanted to recommend avoiding dosing people on a Friday or before the weekend, because then if there's any issues, there's no one to check in. So another lesson learned was analgesia. And for our clinic, the injection pain was the most common reasons that the youth didn't want to continue Sublocade. And this seemed to be worse for patients with low body fat and the younger adolescents. Sublocade is an injection of 2 mils of a viscous liquid that goes sub-Q right by the umbilicus. And all of the youth that have been in the program have been very slim. And so you're pushing quite a lot of liquid into not a lot of tissue. And the needle is also a wide 19 gauge needle. So Jonathan was one of our first patients, and we hadn't at that time come up with all of the things that we're doing now. But some of the things that we've learned over time to prevent pain is pre-medicating people with acetaminophen and ibuprofen, and also with lidocaine. We've used a lidocaine topical ointment, but we're looking into starting to use an injectable lidocaine to just give a little bit better analgesia. Some of the patients have done well with some lorazepam ahead of time. The anxiety seems to contribute to the pain. I think they tense their bodies up and they just have a worse experience with it. Ensuring the dose is at room temperature. It's kept in the fridge, so you want to make sure that it's not cold when it's going in. Icing the area before and after. And the most important thing probably is to inject really slowly and steadily over at least 60 to 90 seconds. And the last little bit is kind of the pinchiest. A couple other things we've done is things like asking youth if they'd like to have any particular music on, or if there's people that they'd like in the room to hold their hands, that kind of thing that some youth have benefited from and some have not wanted to do that. And lastly, readiness. This is probably one of the things that I worry about Sublocade being released. I think Sublocade is a really excellent drug that can really be life-changing for the minority of patients with opioid use disorder. So this drug is really great for people who would do well on Suboxone and for people who have substance use goals of really trying to get away from using and stabilizing their life in that way. So it's not a good drug for somebody who would otherwise need methadone or Kadian or IOT. It's not a good drug to give to someone without full informed consent and like without the patient being on board, because once it's in, it's in. It can be surgically removed in the first 14 days, but that would be a pretty large ordeal, and so it's generally just in. And so the patients need to understand that it will wear off over time, and that also if they try to use substances, it's going to be blocking some of the high from opioids. So we have seen that in some cases, youth have increased their use of stimulants or other substances. And I think part of that may be that maybe the Sublocade was given at a time where they weren't quite ready in their readiness to change, or maybe just readiness to change in certain substances, but the goals need to be congruent. So I think that's probably my biggest takeaway is this will not work in the way that we use sometimes antipsychotics for people who are unstable. This drug is not for that. This drug is useful for people who are would do well on Suboxone and want something that's not taken daily and who can tolerate pain. So I do think it's been really, really excellent and life-changing for many of the youth, but I just want to caution people against using it at all in a coercive way.
Thank you. Before we move on to Dr. Sharifi, we have a couple questions in the chat, if that's all right.
Yeah.
Could you comment more on the injection speed?
Yeah, so when you get the injection, so like I said, it's a 19 gauge needle, which is big, and it's going just subcutaneous, so it's like 45-degree angle, and you have to pinch the skin. So you actually have to use quite a bit of pressure to push it in, and so getting that pressure slow. If you push it fast, it just hurts a lot more. So what I've done usually is let the youth know. Most people find that this is less painful if it goes slower. So I'm going to go slow and like let them tell me if they want me to speed up or slow down. And people generally, once it speeds up a bit, they'll want it to slow down. So the slower and the more steady you can get it, the better. And just making sure to not let go of the skin that you're pinching at the time. After giving the injection, to not rub the site, just put a Band-Aid on it and then remind the person not to let their waistbands on their pants kind of rub on it or anything that could be irritating, and you don't want to press on it either. But yeah, the injection speed does seem to make a really big difference.
One of our guests mentioned that they heard another presenter say that there's some physicians recommending injecting rapidly. Dr. Sharifi, I'm wondering, do you, with your expertise as well, do you also recommend the slower injection to help with pain?
Yes, so we have about 30 patients in the federal correctional system on the Pacific region, and generally we follow basically what Karen mentioned, and we inject very slowly. Now you can't do it too slowly because you have a 19 gauge needle inside, but we try to keep it around the 60 to 90 second range as well. And the only complaints we've had so far with injections is early on when we injected a little bit too quickly.
Hmm. I think that was similar for us. Like I think the case with Jonathan, he was one of the first. So I think that the injection was probably done a little bit quickly, with maybe too much of an audience as well. So I think that was a couple of other factors.
Another question here for you, Karen. It says, have you had any success with a 100 milligram maintenance dose? Did those patients have a lower prior opioid use compared to the ones you discussed?
Yeah, that's a really good question. So far, we haven't actually stepped anyone down because they basically all have pretty high opioid requirements. There is a new one that we're just starting to work with, and I'm thinking we will be able to step down, but that's quite a young youth who doesn't have a long history with opioids. But yeah, I don't know why that is. There hasn't really been much research into that, but if the opioid needs are not being met to the point that they're needing clonidine and breakthrough Suboxone, I don't see that we can really reduce it to 100. And the best thing I can really, my best guess is that they're using fentanyl and those dosing requirements were probably intended for heroin, but I don't know if that's actually true. That's just my best guess.
Does Sublocade leak from the site after injection?
It can a little bit, but just put a Band-Aid, don't rub it.
For both of you, have you had any patients that were on methadone that you eventually transitioned to Sublocade?
You go ahead, Nick.
None yet for me. So Karen, it's
Yeah. Some of mine had been on it previously, but not at the time they were coming onto the Sublocade.
Have you had any patients ask you to stop midway through the injection, and what would you do if this happened?
No one has said to stop midway, but some of them have just been like, finish it, finish it. I think if someone told me to stop midway, that's a good question how to manage it. I'd have to see the actual emotional tone and everything that was happening in the room. I don't think I can say exactly what I would do at that time. I will hope that I could reassure the person and finish the injection, because you don't really want to get half of the drug in and then you have no idea what the person has on board. But ultimately, if somebody revoked their consent, I would stop the injection.
Thank you. Okay, we're going to move on. So Dr. Sharifi, you can take it away. And again, folks who have more questions, we'll get to some more at the end of this presentation. Go ahead.
Thank you so much, and thank you for the introduction. So my name's Nadir, and I work in two sides of the correctional system. And if we can go to the next slide. I don't have any disclosures. We can go to the next one. And just to let you know, so I'm the medical director for Correctional Health Services, which is part of the Provincial Health Services Authority, and we oversee healthcare within BC Corrections. So it's a provincial agency, and that's my administrative role. The talk I'm going to give you is based on my clinical role, which is as a family physician within Correctional Services Canada. And just to give you a little bit of a primer of corrections, as I said, there's two services within Canada. One is Correctional Services Canada, which is a federal agency, and it's for anybody who's sentenced more than 2 years would go to a federal institution. And then BC Corrections, which is provincial, anybody with a sentence of 2 years less a day, anybody who's waiting for trial and is high risk would be in a BC Corrections facility, and also immigration holds that are high risk would be held in a BC Corrections facility. The sentence of 2 years less a day, that's just arbitrary, and it varies from different jurisdictions. In the US, for example, a state sentence would be 1 year. In Canada, we use 2 years, basically. And when it comes to the prevalence of substance use disorder, the federal corrections data shows that 80% of incarcerated persons have a history of substance use disorder, but the BC corrections data, which is a little bit older, and we should have new data coming up soon. The previous data showed that there's 60% of the population has a substance use disorder and or mental health disorder, but in actuality, I think it does mimic federal corrections, and we definitely have a very high prevalence of of substance use disorder within the incarcerated population. So this slide you see is the institution where I work at. It's called Pacific Institution and the Regional Treatment Center. It's in Abbotsford. And this is a facility that holds about 400 individuals. If you look at disease prevalence in correctional medicine, and again, it's very similar to a marginalized population that we see, for example, in the downtown east side. There's higher prevalence of HIV, hepatitis, TB. We do have an aging population within corrections, and as I mentioned earlier, there's a high prevalence of substance use and mental health illness. In terms of Indigenous persons within custody, unfortunately, excuse me, the number is quite high. It's about 30% for federal corrections. In BC corrections, it depends on the location of the site. But at our facility in Prince George, up to 60 to 80% of incarcerated persons at any one time may be First Nations. And the other thing to consider, and this is the World Health Organization Prison Health Guidelines that came out in 2013. Their request is that when health is provided within prison, there should be integrated within the health service in general, within that region, which means continuity of care within custody to outside in the community. Equity, somebody within prison should have a healthcare system that's equitable to somebody in the community would have, and autonomy that healthcare is provided without pressures from the correctional or prison operation side. So we can go to the next slide. This is a handout that came out not that long ago from Federal Corrections advertising Sublocade for the incarcerated persons population. And I'll get you to go to the next slide. And this is a fact sheet also intended for patients just to let them know a little bit about this new medication that's come out. So Sublocade at CSC, and CSC is Correctional Services Canada, was approved in June 2019, around the same time that I think Foundry started using it. Foundry, I believe, correct me if I'm wrong, Karen, but you guys were the first to use Sublocade in Canada as far as I know.
I think that's right, yeah.
Yes, and so within the Pacific region, so British Columbia, there are about there are roughly 2,000 plus federal inmates. Of those 2,000 plus federal inmates, about 400 plus are on OAT. Of those 400 plus, about 30 are on Sublocade. The majority are on Suboxone, but it's if you look at the ratio, it's probably Suboxone first, methadone second, and then Sublocade is way down on the list. And Cadian is not approved for OAT within federal custody, although Cadian is the formulary long-acting opioid that's available. So there hasn't been any issues in terms of any people in the community who are on Cadian who come to the federal system, they get continued on their Cadian. But within federal corrections, Cadian is not on their opioid agonist treatment option list. It's basically methadone, Suboxone, and Sublocade. And for your information, Suboxone within federal custody is the film. We don't use the tablet anymore. There's the Suboxone film that sort of attaches. We attach it under the tongue and it dissolves. So now, of the 30 or so clients or patients that we have in the Pacific region on Sublocade, I'm going to skip the next part and we'll readdress sort of complaints about Sublocade later. I'll go straight into the case studies, and we'll start with Mr. A. And just so you know, prison is from the community, and it's an enclosed congregate setting. There is limited access to drugs from the outside of from substances from the outside, even though they do exist. But in terms of access, it's obviously way more limited than the community would be. So Mr. A is a 44-year-old gentleman. He's had a very long history of intravenous drug use, opioids and stimulants starting in his very early 20s. He has an indeterminate sentence, which means he's a dangerous offender, and it's up to the parole board to assess whether he can get out or not. So there isn't a fixed sentence. He was in provincial custody for about 6 years before he came to us a couple of years ago. And he was in the province essentially as pretrial, waiting to go through the court system to be sentenced. And he came to our facility on Suboxone, and he was on Suboxone 24 milligrams. He was also on Wellbutrin, which is an antidepressant, and gabapentin, which is a anti-epileptic drug. And within custody, there are certain medications that are high commodity. They have value and abuse potential. And unfortunately, Wellbutrin and gabapentin fall into that category. So I saw this individual after some of the officers had noticed that he'd done some what we call diversion, and we'll talk about that in a bit. But he had diverted his Wellbutrin, and I was seeing him because of that and providing some counseling. And we didn't discontinue his Wellbutrin, but as I started to see him more regularly with visits, he was on Suboxone and doing quite well. No cravings or use within custody, and no withdrawal symptoms. But he'd wanted to come off his Suboxone. He'd asked me to taper him off his Suboxone, and it didn't quite really make sense to me. So I tried to sort of delay that and counsel him as much as possible. And what came to light on the second or third time that I saw him is that he was being pressured for his Suboxone. So Suboxone is a commodity within the correctional setting. It does have value. I've had prices range from $5 to $80 for a Suboxone tablet or strip being sold within the custodial setting. And this gentleman, Mr. A, he's a little bit on the frail side, and he would be considered at risk of being a victim. So we looked at different options. Methadone was one, but we talked about Sublocade, and he was the first person that agreed. And of course, it's voluntary. He agreed to go on Sublocade. And the advantage is that if somebody in custody is on Sublocade, they don't have to come up to the med window every day for the nurse to give them the Suboxone. And those med times are very early in the morning, around 7:30. You're standing in line with 20 or 30 other inmates. So the Sublocade essentially eliminates that. The other thing the Sublocade does is it's given in the nursing in our clinic. So none of the other inmates would know that somebody is coming in to get Sublocade. They're coming to see the doctor for could be a number of things, and then they just happen to get a Sublocade injection there. So this individual agreed, and he was the first person we put on Sublocade. So we give 300 milligrams, and then we repeat 300 milligrams in 4 weeks. So we do 2 300 milligram doses, and then we step down to 100 milligrams. And I think our experience is a little bit different from Foundry because there isn't any heavy active drug use. If there are substances, they might come and go, but it won't be a situation where somebody would have regular access to opioids within custody. So this gentleman was on 24 milligrams of Suboxone, and we stopped, and the next day put him on Sublocade. And again, he essentially complained of pain from the injection, and it turned out we were injecting him too fast, and we learned from that. But everybody in custody that we put on Sublocade, we monitor them weekly. We do a COWS and we check the site of the injection. One of the concerns we have in custody is if that bead, the Sublocade bead, is going to be dug out or extracted, and then possibly inmates may try to melt it and inject it, and there's always a worry of causing an embolus if you do that. So we do regular checks just to make sure that the bead is there and slowly fading away. And this gentleman actually did quite well and continues to be on Sublocade at 100 milligrams every 4 weeks, and so would be considered a success. The second individual, Mr. B, this is somebody who was in law enforcement and unfortunately ended up in custody with no history of opioid use in the community. But he essentially became addicted to opioids within custody, and Suboxone, especially in well, whether it's in BC corrections or where the federal system is diverted heavily. So it's not very hard to get this Suboxone. In the province, they do crush it and snort it, and in the federal corrections, because it's a film, they light it and smoke it. So there is a buzz or a high associated with this, but of course, if you're doing that regularly, then you're going to essentially become dependent. And so this individual became addicted to opioids within custody, and he chose to go on Sublocade because essentially convenience of not having to get up every day and go stand in line to get Suboxone, the convenience of a four-week injection. And he did quite well. He had the 2 300 milligram doses and then a 100 milligram dose. And then he said, listen, opioids were never my thing in the community. This was something that happened in custody, and I really don't want to be on any opioid agonist treatment at all. Let's just stop and see how I do. And he probably was at steady state because he'd had at least 4 or 5 doses of Sublocade. And we did continue to monitor him, and he really did not have any significant withdrawal symptoms, didn't require any clonidine, and continues to do well. He does have some mental health issues and is on psychotropic medication, but I would probably consider that a success with Sublocade, and we've he's the only person that we've actually he's the second person that has come off Sublocade, but this went relatively smoothly. And then we're running out of time, so I'm going to quickly go to Mr. C, who is a 50-year-old gentleman in custody, and this individual also came into custody not addicted to opioids. It developed an addiction within custody to opioids and ended up on Suboxone. And we inherited him from the provincial system on Suboxone, also 24 milligrams. And unfortunately, this individual was caught several times diverting Suboxone. And the problem with diversion is something that is relatively common in the prison setting. There's very little literature on it. The textbook of correctional medicine doesn't even use the word diversion, but it does happen. And if you Google it, there might be a token journal here or there that make mention of it, and lots of anecdotal evidence from other physicians that work within prisons. But the issue with diversion is that we don't know how much the individual is taking. He wasn't forthcoming in terms of diversion or of being muscled, and so there is some risk in continuing to give him Suboxone within custody. And we did provide him options that he could use. Of course, their methadone was one, and Sublocade was the other. And he did agree to go on Sublocade, and again 300 milligrams, 300 milligrams, and then down to 100. And he's done again exceptionally well. We only have currently 12 people within my institution, and we follow them regularly. And we can go to the next slide. I've only had one person come off because they didn't like Sublocade, and they said that they continue to have withdrawal symptoms and cravings on the Sublocade, and unfortunately weren't willing to sort of continue it either with clonidine or supplemental Suboxone until we achieve steady state. So that person is back on Suboxone. And again, it's quite possible that the motivation is because Suboxone is a medication that can be diverted. So that, but regardless, we try to maintain patient autonomy as much as possible. So the challenges of providing OAT within custody on his medication adherence and diversion, which we talked about, the misuse, coercion is an issue. It is a commodity. We worry about the safety of the individual and the safety of the institution with diversions happening. Ultimately, we try to be as patient-centered as possible. But because about 30% of our patients are on Suboxone or OAT, the med lines are very long, and nursing resources are put into administering Suboxone, where Sublocade would obviate that need and allow nurses to provide clinical care. So I think our long-term goal would be to encourage as many people to go on Sublocade. It would work for our facility, for prisons in general. But again, we can't force people to take Sublocade. It has to be an education sort of process, and that's why the ethical consideration is there. Is can we sort of say Suboxone is not available, your only choice is Sublocade, and we have had that go through our PHSA ethics board, and it's a gray area, but we've chosen at this point to respect the patient's autonomy and try to educate patients. And what happened with Mr. A, who was the first one, he basically started advertising Sublocade, and that's how we ended up with the number of patients that we had. So I think within our context, it's a medication that has potential. And now that we have special authority, transitioning these clients to the community will be even easier. And that's it for me.
Great, thank you. I'm just going to read a couple more questions. I know we're almost out of time, but wanted to get through some of these.
Absolutely.
There's a question here, any difference in acute pain management versus sublingual Suboxone?
That's a good question. And so far, none of the 12 patients that we've has gone to hospital for any acute pain issues. Usually, I also oversee the medical hospital in federal corrections, and for our general Suboxone patients, I just continue their Suboxone and add a high potency narcotic opioid for pain control needs short term. I would probably do the same with Sublocade, but I don't know if Karen, if you've had any experience with acute pain.
I haven't, but one of the things I've been wondering is whether we should be getting medical alert bracelets for our patients, because if they're injured and people don't know they're on Sublocade, that could be a major problem. But at this point, there hasn't. They're young and they haven't really had any pain issues. But it is interesting. One of our patients has been wanting to like advertise and tell all the other youth, and she was very excited to be one of the first people. So I thought that was pretty cute.
How long have some of your patients been on Sublocade successfully? I think you covered some of this, but maybe Dr. Shivaji, some of yours.
Yeah, so we had approval in June, and but again, it wasn't until September. So we've had patients since September, and I would say having 30 within a population of 400 on on oat, that would be I would consider that a relative success, considering it is an injection and it is invasive.
Would you ever use 2 sites of injection?
I don't think so. I don't think what we do is we do what the monograph says, which is we rotate in the 4 quadrants on the abdomen. But I don't think there have been any studies with 2 injections, and I would be hesitant to do that.
We'll take one more question here, and it says, would you use Sublocade with pregnant women?
Well, the monograph says no, and I work in a male facility. So Karen, have you had any
Yeah,
experience with?
I can speak to that. Buprenorphine is not teratogenic, but the Atragel that the Sublocade is in is teratogenic. So all of our female patients, we do a pregnancy test just the day they get their Sublocade, and we really encourage them to be on reliable contraception.
Great. We didn't get through all the questions, but hopefully we can come back around those into part 3. So if you want to join us, we're going to be hosting part 3 of this webinar series on June 9th, which is going to be all about diving into the research around Sublocade. And so this is going to be a journal club format. So all of you joining us today are definitely welcome, and we encourage it if you want to have a deeper discussion with some of our experts on the research. I'm going to go back one slide just to say, as always, here's a list of important resources for you. We covered many of these in part 1 of this series. An important resource, again, to reiterate, is that this first resource here, the Sublocade Bulletin by the BCCSU, which goes through all of these details and everything you would need to be able to get a patient on this medication. And with that, I'm going to wrap it up. Thank you so much, Karen and Nadir, for walking us through those cases today. This was tremendously helpful, and I'm seeing in the chat that people are delighted that you went through those cases and found it helpful. Thank you so much, and thanks to those who joined us today, and see you at the next one.
Great,
Bye.
thank you, everybody. Bye.
Thank you. Bye, everybody. Bye-bye.